With so much information out today, the Google, the WhatsApp, ChatGPT, all that, how are people really coping with cancer?
Patients and their families go through enormous amount of emotional difficulties, even utter the word cancer. That's primarily because the way cancer has been perceived thus far. Because one, I think, largely the damage has been done via movies and what the media has been kind of creating negative hype about this.
All the movies are always showing patient dies in the end.
Yes.
That is not the case in real life.
So cancer is perceived as being, terminal, or they're not going to make it, it's incurable and so on. So therefore, when they come to your office, they will ask you for guarantees. They will ask you whether, how long they're going to live. It is always tied with longevity. Unfortunately, we don't have answers. The good news is that we know how to deal with it.
And also we have termed them as cancer victim. We don't say diabetic victim,
Yes.
the cart victim. We say cancer victim.
Yeah, cancer survivors.
Yeah. From the psychological viewpoint, when a patient comes, what does he or she expect from the doctor?
I think a lot of it is in the communication. The art of communications first is to listen. Most often patients already know a whole lot of things. The families are also a little worried about, they will have to spill the bean about a lot of things. So therefore they're very afraid that the whole thing will just, what they've kept it under wraps, will come to the fore.
So the families are also afraid.
Very afraid. Very often.
They want to keep it under the rug.
Yes, there is also that resistance. The suicide risk in cancer, Dr. Ajai, is 4 times more than the general population and psychiatric population.
Hello everyone. Today we are doing a podcast with a very renowned person. She is a psycho-oncologist, Dr. Brinda Sitaram. She is also a researcher and she has been working in our HCG for a long time. In fact, we started psycho-oncology nearly, Brinda, about
32 years
ago. And one of the things as an oncologist, having practiced in US for a long time and working in India and being founder of HCG group of hospitals, it is really amazing to have a person like Dr. Brinda Sitaram, so dedicated to the psycho-oncology part. And I will give a brief background before discussing or dialoguing with Brinda Sitaram. See, in medicine, we as doctors always feel that we are giving an opinion to the patient. For let us say a cancer patient, we are giving an opinion what should be the right treatment. And we always think the patient has understood, the patient has comprehended. When the patient says, okay, I have agreed for the treatment, we think our job is done. But what we don't know is what goes on behind the scenes. What is the patient dynamics of accepting this disease? How are they handling with the family? And how is the family dealing with this disease? What is the dynamics between the patient, family and society? What is the fear the patient has? See, we normally tell the patient, don't worry, it is okay, you will do well, or you have metastatic disease, I will put you in remission. We only talk about the medical aspect. As doctors, we are not trained to talk about the psychology aspect of it. And unfortunately, a lot of doctors also think we are also giving therapy to patient by just putting a hand over their shoulder and saying, don't worry, well, everything will be all right, these are the drugs or not. But really, we are not really addressing the main issue. And this comes to us as a feedback from patients, their relatives, and also the financial issues are there, other issues. Counseling becomes very important part of winning the game. And Brinda has actually written a book called Winning the Game, Not Out.
Not out, winning the game of cancer.
Not out, winning the game of cancer. She is an authority in psycho-oncology and she pioneered the work in India. And she's trained abroad and done a lot of work in India, trained people in India. It's really a pleasure to have you, Brinda.
Thank you.
I would like you to elaborate on some of the statements I made as a doctor. And how do we have to gear up for this? With so much information out today, the Google, the WhatsApps, the chat GPT, all that, how are people really coping with cancer? Not only how they respond to treatment, how are they coping? And how do you see your role now and in future? And what kind of dynamics will be playing there? And how do we make sure the patients have really a positive approach to this disease, not only in terms of the disease bodily, but mind also? How do we do it?
Right. First of all, thank you very much for having me here. And I think you really kind of nailed it. And I think we started off even in HCG years ago, primarily because of the vision that you had, largely because of all that you said. Patients and their families go through enormous amount of emotional difficulties. When we even utter the word cancer, that's primarily because the way cancer has been perceived thus far. Because one, I think largely the damage has been done via movies and what the media has been kind of creating negative hype about this and so on.
All the movies are always show
Yes.
patient dies in the end.
Yes.
They feel all the movies. I remember Anand, the English movie, Terms of Endurement, everything is,
Right.
it has to end.
Absolutely.
So that is not the case in reality.
In reality. So very often, humorously, I tell my patients also, 99% of marriages also fail because of what they see in movies. Because in reality, marriages are not made that way, right? So coming back to this, I would say that yes, from the time of not even the diagnostic phase, I would say pre-diagnostic, when you start uttering the word biopsy itself, the anxiety builds up.
Yeah. Anxiety.
Yes. And lo and behold,
Fear of unknown.
Fear of the unknown. And the word itself, they start to think that biopsy means it is going to end up as a cancer. And then the cancer terminology, the way it has been perceived in the society at large is that even we talk about cancer as a corruption, even in, we draw parallel with,
So that creates fear.
Absolutely.
Somebody goes and says,
Absolutely.
cancer, corruption of the society is like cancer.
Absolutely.
So people, wow,
Yeah.
that means I'm so bad, the disease is so bad.
Yeah. So,
Like the other day, when doctor came to our tumor board yesterday, you were there, I think. He said, we thought, we saw all this presentation in the tumor board, but we thought anybody with metastatic disease is not going to live long. I learned so much today. Like even among doctors, there is that feeling.
Yes. That's also primarily because, Dr. Ajay, we've classified diseases in society as good, bad, big and small.
Yeah.
Common cold, the word is common, so it's okay. Diabetes is called sugar, so it's the sweetest thing to happen. We don't mind talking about our heart, cardiac issues, But cancer, unfortunately, is pushed to this corner of being big and bad. And it is considered terminal. So the terminologies we use also is important. We are all terminal the day we are born. Cancer doesn't alter that equation.
We use palliative, terminal,
Absolutely.
stage 4.
Yes.
Create fear in the patient. Rather than making sure the patient's reality check is given, we create fear.
Right. Even from a psychology...
Where do we expect them to understand?
Absolutely. Now, even from a psychology point of view, or the mind point of view, everything is neutral. No object, no person, no context by itself has any meaning. It's the way we look at it. I look at a rope and I believe it's a snake, then there is panic.
Correct.
So cancer is perceived as being, terminal, or they're not going to make it, it's incurable and so on. So therefore, when they come to your office, they will ask you for guarantees. They will ask you whether, how long they're going to live. It is always tied with longevity.
And also we have termed them as cancer victim.
Victims.
We don't say
survivors.
diabetic victim,
Yes.
the cart victim. We say cancer victim.
Yeah, cancer survivors.
Yeah, survivors.
Yeah.
As though, cancer, we have really beaten it. It's so unbeatable. We are the few who have beaten it, so we are survivors.
Yeah, we never say we survived Bangalore traffic, isn't it? So I don't see why we
And we don't say even I survived a heart attack.
Yeah,
So
absolutely.
all of this, you are absolutely right.
Yeah, so it's all in the perception, the way we have perceived things. So therefore, it starts from the pre-diagnostic phase, an entire continuum in the trajectory of cancer journey itself. there are all these, myths and misconceptions. For example, you say chemotherapy. There is so much of hype created by chemotherapy. They don't understand chemo is drug. Any drug-oriented treatment is chemotherapy. We use antibiotics. We use a painkiller. And each one comes with its side effects. But here, because we use a combination, there are bound to be some side effects. And most of the side effects...
You are saying what is so different between oncology therapy and antibiotic therapy? All are chemotherapy.
They're all chemotherapies. Yeah. Nobody explains this to them. Don't educate them about this.
Nobody explains.
Yeah. And also, I think what happens, Dr. Ajai, is that the first day they come to you, they have 3 fundamental questions for you. Why did this happen?
Correct.
When did this start? And what is my future? Unfortunately, we don't have answers to all the 3 questions because cancer is an enigma still. The good news is that we know how to deal with it. Why it comes, we've only identified risks thus far.
Yeah, from the psychological viewpoint, when a patient comes, what does he or she expect from the doctor? Do they expect the treatment to be elaborated? What is the treatment by? Or do they expect some psychological counseling also from the doctor? Or do they really like an expert to explain to them? What is, in your view, is majority feel in this aspect?
I think a lot of it is in the communication. The first stop is always with the primary doctor. The truth begins at that point of time. And all communication is about, the art of communications first is to listen. Yeah. Most often patients already know a whole lot of things, number 1. Number 2, even to understand from them, what is it that they want to know? Sometimes people don't want to know anything. They will say, I trust you, just go ahead and treat me.
And what about the trust factor?
Yes, the trust is again because of the communication issues. Oftentimes they believe that they're not told. And what happens when we're telling things also, on day 1, if we flood them with information.
Do we have to repeatedly talk to them before they go first therapy?
I believe that truth is also like medicine. You have to give them in doses. You have to break it down and give it to them. First day they're in a shock phase, they're in the numb phase. And at that point we're talking
about... What of them they don't absorb?
Nothing is absorbed. That's how they come back to complain and say, you never told me anything. So good idea after we've finished our conversation to say, can you summarize what you heard so far?
Well, that's a very good point.
Yeah.
You ask the patient and they let you to summarize.
Yeah. When they summarize, there are gaps or they have chosen to hear what they wanted to hear.
Correct.
You fill those gaps, then the communication is complete. And then always sign off asking, do you have any more questions? Is there something else that you may want to ask? Because first day, we have to spend that quality time. So if we move them to psycho-oncology, let's say on day 1.
A lot of doctors, time is an issue.
Right.
It's not that they don't have time, but spending time with the patient becomes very limited.
Right.
How do we address this issue?
Yeah, that's a very good point. And I think this is something that most doctors also come back and tell me. I think what we can do for a start is to find out, like I said, what is it that you know so far and what is it that you want to know. And then break those news. For example, on day 1, instead of saying, I'm doing surgery, you'll have chemo, you'll have radiation, and so on, is to split the information. 2, sometimes communication can be in terms of written form as well. We give them a jacket which carries a lot of information.
But it's nothing like verbal communication.
Absolutely. And next is to always say that I have so and so who will help you to understand, which you do so often in the clinic. In all your CKOPDs, you do this very often. You will talk to the patient and then you will hand over. There is your treating doctor who will be talking to you, and then, there is a psycho-oncology team that will be facilitating this. So what happens is we all start to speak the same language. Then the trust element starts to, there is that element of trust that will come.
Recently, I interviewed a patient, a young man, Suraj. He came on and we talked about him. What was amazing thing is, he was very categorical. Psychology counseling made a huge difference for me and my family. Really, it made me accept the disease. It made me be comfortable with myself and undergo the treatment in a non-stressful way. I think it's an important point I also appreciate him telling. And coming from patients is very, very critical, we address this issue in a proper way. So what do you think at our HCG? How are we going to address? In the past, we have tried to pre-screen psychology, we have done everything, but we have not succeeded that well. Every patient is not exposed to you or your team.
Right.
How do we bring about that?
Yeah.
What are the impediments?
Right. The barriers that have existed is there is a stigma to meet with a mental health person.
Stigma from whose side?
Both sides, I would say.
Doctor as well as.
Yes. For the doctor, I won't say it is so much the stigma as much as he believes at that point is, just get rid of the cancer, everything else will settle down because that's a priority.
Let's get the treatment going.
Yes, that is number one. For the patient also, now I have cancer, let me be rid of this, other things will follow later. And then it's a double whammy. The cancer is a stigma as they believe, and then meeting with us is another stigma. So that is one aspect of it. Two, Dr. Ajai, it's very important that insurance or schemes don't cover them. It's an out-of-pocket expenditure. So very often the resistance is also because of this. And I know that we have rendered this free. So we have really done, yes, we have rendered this completely free. So that is one barrier that we were able to break. The second important barrier that we broke within HCG is also, I think, largely to what you did was, to make sure that we were given platforms in tumor boards to talk, or, cases that we had seen, you would make sure that we kind of voiced what exactly we had done and so on. So those things started to slowly loosen out a few of the barriers that existed. From a patient point of view, I think very largely, even when I decided to come back to India, the resistance was they believe that we have strong family network and we are spiritually very strong, so we don't really need this.
Yeah.
While the belief is, yes, sure.
There is another problem.
Yes.
The patient feels I don't need it.
Yeah.
The doctor also agrees.
Yes.
So in the end, they don't get this amazing counseling.
Right.
What they can really handle better.
And very often the families are also a little worried about, they will have to spill the bean about a lot of things. Actually, what happens in psycho-oncology is also, the truth is that you have to just scratch the surface. There are a can of worms there.
Yeah.
Plenty of, family related issues and life events that, the family member or the patient has gone through and so on. So therefore, they're very afraid that the whole thing will just, what they kept it under wraps will come to the fore.
So the families are also afraid.
Very afraid. Very often
they want to keep it under the rug.
Yes, that is also there is also that resistance. But what I'm kind of happy today after this 30-year-long journey is that slowly things are beginning to kind of warm up. Like you mentioned about Mr. Suraj, who talked to you. These are people who actually lend a voice to psycho-oncology.
Yeah.
When they start coming up in the open and to talk about the emotional difficulties they had and how it got resolved, then many more will start to follow. That is where even our support group is of great help to us, where we're able to...
Doctor, let us talk about support group and we'll come back to this. For you, while you counsel, how important it is a patient should also, who's been in treatment before, who form under our Pink Hope support group, they also call or have a meeting with the new patient. How important that is?
It is very important.
On a scale of 1 to 10, where would you put it?
I would definitely give it a point of 10.
Oh, really?
Why? The reason being, we have a certain role as professionals to handle certain very complicated, intricate issues. But coming from a person who's embarked on this journey successfully and reached that goal or destination very effectively, then that gives them that much more courage. But what we have done in HCG, Dr. Ajai, and you're aware, we have trained all our patient volunteers.
You trained?
They have gone through workshops of the do's and don'ts, what needs to be communicated, how to handle. And they also go through enormous amount of trauma when they're listening to a newcomer's story because there's a lot of flashback of their own. So we have debriefing services for them where they talk, they, voice up whatever difficulties they had and so on. And it's navigated by a professional. Me or my team members.
How many such teams do you have? I mean, the people who belong to this Pink Hope group, you counsel them?
We have about, for now, about 20, I would say.
That's a good number.
That's a good number. And largely where we are using this is majorly with women, I would say. because they are the ones, particularly breast cancer, they want to know about the hair loss, whether the hair will come back. And when they see people, we have a dancer in our group who says she did her arangetram and sat at that post chemotherapy. That was even this morning. That was very heartening for a young person who is to now start her journey in this. So they have a significant role, provided they are kind of under the umbrella of a profession.
So most patients would welcome this interaction with a former patient who has gone through the treatment. Most of them would welcome it.
Yes, I would say the way it is put across and the way we encourage them to do it, that's very important. Because if you just say somebody will come and talk to your patient, that they will not accept. But if you tell them, listen to them so that then everything sounds real for you, then they're very happy. Because I've gone back to ask, how did it feel? They said, no, it gave me a lot of courage. And the beauty is these volunteers continue to keep in touch. Okay. And I always tell them that, no, whatever you got a benefit, at some point I'll ask you to come back and give it back to many more patients. And that's how we rope in many more volunteers and so on.
What is when we look at, we all understand now, we agree that patients needs this psychology counseling. And particularly, it may not be just about oncology, it was about all the other issues which surrounding it. Because we want them to have a good quality of life.
Absolutely.
As they move forward. Good quality of life is not just taking care of cancer, but all the other things, baggages they've been carrying, which may be related to cancer, may not be related. But now, since their lifestyle may change, we have to make sure the quality is like that. So what is it an organization like HCG can do? Should we start a program for psycho-oncology itself, a defined program? And we have some program, but should we expand it? Should we recruit more people and obviously have a better budget? What is your wish list?
All that you said is my wish. I will start off by saying, yes, absolutely we need bandwidth. Primarily because psycho-oncology has a whole gamut of things under it. We have sex therapy, we have marital therapy, we have something called the brain lab, because neurocognitive difficulties are very well known, not only in neuro cases, but we know several of the chemo agents can bring about certain neurocognitive changes. All of this is reversible. Even in the pediatric realm, children go through a lot of learning disabilities and so on. So we have a role. Tobacco cessation, de-addiction, we have a significant role.
While we can do all this wide spectrum of things, when we have a focused factory approach to our own patients, what is few single most important things we need to in our institution to change, make it more accessible for them, and they should be more aware of it, and how do we also measure the outcome for a part of our research? You have done some work on that, so you can explain that.
See, one is, of course, we need the bandwidth. We need manpower to facilitate a big organization such as HCG. Take only our KR unit. There are so many patients. Yeah. If indeed we want to screen all the patients, because then the red flags can start coming up. The red flags can come up, and then we know we have to start to intervene with these patients. Lo and behold, each one will have a red flag coming up at various points of time. So routine screening is important, for which we need to empower.
So there is still a place for this kind of screening?
There is absolutely a great place for screening. That is a must.
Is something like artificial intelligence play a part in it? Can you create some algorithms when you interview people and say, okay, this is how, and in your training modules can you use, this is what a cancer is. I'm sure people have done work on that. But can we come up with a publication on using this? This is how we should approach. See, for example, what we say is sometimes to the patient, we assume that is what they require. But their requirement may be different.
Absolutely.
So through this AI and all, can we develop some ways, some algorithms, so that could become the helping hand for them? And then we also learn from it. Because my view is we should also learn from these patients. A lot to learn.
Absolutely. Absolutely. Every patient is a university. They teach us a lot.
Yeah.
Yes, there are n number of screening tools and measurement tools and so on. Even for quality of life, we can quantify it. We can quantify their distress. We can quantify even their psychosocial difficulties that they have and so on. And that's a good platform. Now everything is going digital, so we can explore that possibility. But we cater to so many sections of people. So that section that is illiterate, not so educated, not so tech savvy, then we can make sure that, there is dedicated manpower to address their issues and concerns.
You have been a psycho-oncologist teacher. I find, for the sake of whatever it is, lot of institutions are going into oncology, going into psychology, and psycho-oncology being one specialty. Why can't HCG really make a big impact on addressing the psycho-oncology issue as a local problem, global problem, and really do a lot of research and work on it, paper publication? What is preventing us?
It's back to square one, the manpower and what you so nicely said about the budget. So if these two things fall in place, and I'm confident that yes, we can be doing.
I think we should work on that definitely, because there is enormous need. It's not opportunity, it's need.
Right.
And when we want to talk about patient-centric oncology, this becomes a must. What do you think?
Absolutely. Absolutely. And when you talked about algorithm, I think it's important in the flow chart of the organization also to make sure every patient passes through this particular service, because the field is so expanded. When people ask me what is the scope of psycho-oncology, it's from womb to tomb and beyond. Because even after we've lost patients, they come back for bereavement counseling, they come back for grief management. So we have a significant role to play in all segments of this whole cancer journey.
Can you identify in your when you see a patient with all your experience, suppose you are there when a discussion is happening with the patient, can you identify very quickly who are the patient's family required your help?
Absolutely.
So one of the things we should look at is you are there for every consultation. And you say, okay, this patient needs my opinion first.
Right.
So you look at that and decide. I think that is some practice we should start.
Yes.
While obviously you cannot be there everywhere.
Absolutely.
But I think we have to look at this in a serious way and build team. How do we build team? How do we build more people to come into psycho-oncology, see it as a vibrant field?
Yes.
And what is their take-home message? All of this we have to work.
Yeah.
I think, from you, the last question I have is on the patient feedback. What has been in your journey, what has been your learning? Not only about them, as you as a person, how have you changed?
Oh, enormously.
From the patients?
Absolutely. Healthcare, I believe, is a very humbling experience. It teaches you a whole lot, including when you hear the other human stories. It tells you how privileged you are. And then whatever issues you may be having goes to the oblivion. It becomes insignificant. That is number one. Two, it also helps us to kind of not only grow professionally, because I said they're like a university. They give you wealth of information which most books will not be able to give us. Including, there is an internal growth. You grow as a human being, you grow as a person, you become so sensitive to their needs.
So do you start looking at things in a different way?
Absolutely. Perspective changes, Then you're there for a cause, not for anything else. So, you move on from there. One important point before it slips my mind when we were talking about how to facilitate the service for more, I think the screening tool, we can kind of train a body of nurses as well as the social workers while they're in the waiting room waiting for doctors. This just takes less than 5 minutes for patients to tick what are their issues.
Very good.
And there are these standard, tools which takes called a distress thermometer. While they're waiting for a doctor, we do the physical vital signs. Yeah. The emotional well-being now in cancer care is considered the 6th vital sign. So then if they have financial issues, they get navigated to a social worker. If there is physical issue, then they come to a treating doctor. If there are emotional issues, then they come to us. So there are a whole gamut of these problem checklists also that come with the distress screening, which it's a visual analog scale, which rates the distress levels and so on. That's a red flag for us. That can make a very good beginning for us to kind of, take things forward, because the suicide risk in cancer, Dr. Ajai, is 4 times more than the general population and psychiatric population.
Oh, okay.
Even this morning, I have attended to one where the doctor believed the patient looked superficially so fine. He had no indication that she would go
That's an
through something
important
like
point
this.
because that makes, again, that drives home the point.
Yeah.
Every patient, irrespective of what you think, the doctor thinks at a initial level,
Right.
should undergo counseling
Absolutely.
by experts like you and your team.
Yes.
It's not like we can be everything.
Absolutely.
And that is a classical mistake institution and oncologists make. And we are hoping that we are on the path to changing it in a very big way. And I think, Brinda, we have learned a lot and from you in the last 30 years. And today, again, you have re-emphasized a lot of points about psycho-oncology. And particularly today, mental health address is becoming a very big issue. Generally, non-oncology, particularly youths, people, the behavior patterns, lot of counseling they need. So when you are looking at it generally, obviously cancer patients have to be more specialized, focused factory approach.
Absolutely.
So I hope we can develop this further in HCG with your more aggressive involvement and more deeper involvement, and let us build a lot of things, including an institution. Okay?
Sure.
And thank you for being here today.
Thank
I really appreciate that.
Thank you for having me. And it's very, I'm reasonably confident we can turn it around very well because of you and your support and the vision that you had 30 years ago. I know that when I came in, you told me that I have arrived 25 years in advance. So I know with your continued support, we can get to that destination that you have envisioned. Thank you for having me. Thank you.